Can I get that with the time? Can you guys hear me? Guys ready? Last talk. Anybody have ADHD in this room? No, yes, admit it. People lie in psychiatry, just so you know. It's upset. No, anybody have ADHD? The guys in the back always do, right? So one of the points of this talk is why we prescribe long-acting meds. Today's a perfect example, right? If you were on a short-acting med, you'd be done by my talk, right? So if you stayed on a long med, you'd probably be locked in. I took my long-acting med at 8 o'clock this morning, so I'm still pretty good. All right, we'll go. So I'm Mike Feld. I'm from Northbrook, Illinois. I know she said Northbrook, which is in the Chicago area. My disclosures are that you guys can see. I also recently started speaking again for Shire since one of their new products just came out. We helped launch the meds. So what are we going to learn today? What are you guys going to learn? You're going to learn, right? We're going to recognize the pervasive nature of ADHD symptoms throughout the day. That is a key point, right? Everyone thinks of ADHD as the pediatricians as like a school-based disorder, right? Hopefully that you're going to leave this talk thinking about morning, midday, afternoon, night, and maybe even sleep, okay? Describe the physical and psychologic morbidity and mortality associated with ADHD, and we're going to learn how to use adult ADHD assessment and treatment tools. We're also going to implement pharmacologic treatment to optimize symptom control throughout the day, okay? Pre-test questions. How often do you utilize rating scales to screen patients for ADHD prior to making a diagnosis or offering treatment for ADHD? Never, rarely, sometimes, very often, always. I told the guys in the back to play the best music for the last one, okay? Please rate your confidence in your ability to select pharmacologic therapy for your adult patients with ADHD. Not at all confident, slightly confident, moderately confident, pretty much confident, very confident. See? I'm a little impulsive. All right. So we're gonna look at some ADHD common myths today. First myth, try a test dose to make the diagnosis. Believe it or not, when I did my psych fellowship or my child psychiatry fellowship in the 80s, that's what people were told. If you gave a little kid or an adolescent Ritalin and they responded to it, methylphenidate or dextroamphetamine, that meant they have ADHD. It's not true, okay? We know that ADHD meds would help almost anybody. They help improve focus, distractibility, overactivity, and impulsivity, and most people would take it that respond to it would have an improvement. ADHD people just have a much more significant improvement. So it is not diagnostic to take these meds. It occurs in boys, not girls. So we know the data is more boys than girls, but there's a lot of girls. In the adult data, it's about thought to be 60-65% male, but 35-40% female. Hyperactivity is the outward marker. I don't know what outward marker, but no, you can't judge just by hyperactivity because actually as adults, the hyperactivity lessens and the impulsivity shifts a little, but the real outward marker is probably functional impairment in life, what the ADHD symptoms cause. Obviously, if you're really impulsive, you're going to see that. But the inattention and distractibility are truly some of the core markers. Children eventually grow out of it? No, they don't. What they do is the symptoms shift, but when you become an adult, you often learn how to compensate better. And with the shift in symptoms, you're in a lifestyle. You do things, you like your job or you're structured, you eat better, you exercise, you have found positive reinforcement. School's pretty demoralizing for most kids with ADHD, so that's where I think you see more because of the pressure and the lack of success and the negative impact of their problems in life that the ADHD leads to. Only take your medicine on school days. Anybody here have kids with ADHD? Children? It's always the people in the back. You notice how the ADHD people sit in the back? That's because they want to sneak in and out. We watch how many times you go in and out of this talk, just so you know. You have ADHD 24/7. The DSM-5 has created a spectrum, so you can have mild, moderate, or severe. And I get why some people with mild ADHD, you might only take meds certain times of the week and certain times of the day. But if you guys live with it, anybody live with an ADHD adult? Spouse, the two people in the back. If you live with them, you know it occurs 7 days a week, right? So we mostly look at medicating more than school, and we look for meds that extend beyond the school day and on the weekend also. Okay, so I don't know if she's the typical looking adult with ADHD, but she's a 38-year-old divorced woman with 2 children, 10-year-old boy, 7-year-old girl. She presents complaining of sleep problems. Do you guys know that ADHD people, in the adult studies for one of the medicines that we'll talk about, lisdexamfetamine, every adult had abnormal sleep. They didn't all meet the criteria for a sleep disorder, but every adult filled out a questionnaire, 100% had abnormal sleep. If you have children with ADHD, you know that they're usually the latest to go to sleep. ADHD people have trouble settling down. It's thought that there's a 1 to 1.5 hour sleep onset latency issue with ADHD. So you always see complaining about sleep problems. Worried about her job, feels overwhelmed, reports feeling stressed and just can't keep it all in the air. Says, I don't know what it is. I'm just struggling right now. Would an antidepressant help? Why did she ask that? Because she had been diagnosed with depression previously and been on meds. One take-home message of this talk, because we're going to get to the comorbidities, most adults that have ADHD often are diagnosed with a mood disorder and anxiety disorder first and put on meds without being looked at. So one of the take-home messages of this whole talk is you have to look for where the ADHD, what's gone on in their life, jobs, education, relationship. We'll talk all about it. But we look for more than symptoms. We look for impact on life, okay? She's otherwise in good health. Her physical exam is unremarkable. Her only meds are oral contraceptives. She's very social, but did not study much in high school, struggled in college, former smoker, drinks socially, and her son has a history of behavioral problems at school. Does he have ADHD? We're going to talk about the genetics soon. So the prevalence of ADHD. What do we know about? Studies have come out lately that even make that first number larger. It's thought that about 8 to 11% of kids, what are kids? We'll call them 6 to 17. If you include the kids in adolescence, you're looking at around 11% of kids in this country. A parent will be told by a mental health professional your child may meet the criteria for ADHD. What do we see? We see the symptoms shift and the ADHD cause less functional impairment in adults, so less adults meet the criteria, but it carries over into adulthood, right? So the data for 4.5% of adults, there's roughly 11 million adults in America with ADHD right now. Probably only a few million have been treated for it, and it's thought that about 6.5 million men and around 3.5 million or 4.5 million women, like I said before. So there's different thoughts in the pathophysiology about ADHD, but we know that there's a delayed brain maturation in childhood particularly. And what does this show? It shows mostly that we know it occurs in the prefrontal region, and if you look at the chart, you can see that you can see the growth delay and then the catch-up at approximately like 15 years old in adolescence. What else do we know? We know that there's genetic and environmental factors for the pathophysiology of ADHD. We know that dopamine and norepinephrine are the key neurotransmitters implicated in ADHD. So any med we talk about, we're going to talk about meds. The primary meds are the ones that improve dopamine and norepinephrine. It's thought that it's a frontal striatal disorder of frontal striatal activity. So I told you it's highly genetic. So if you think about a heritability factor of 0.75, what does that translate to in the adult world? It translates to if you have a child with ADHD, there's at least a 40% chance that one of their biologic parents also has ADHD. And being a child psychiatrist, the long-acting meds have dry mouth as a side effect. Being a child psychiatrist, when you diagnose and treat the parents, you end up seeing the kids do a lot better, right? Because if you miss the diagnosis of an impulsive, emotionally impulsive, disorganized, easily losing things late, a parent that's that way, you see how the kids struggle. And when we treat the parents, we often see the kids improve. I've actually, in my practice, since I'm an adult psychiatrist first, obviously, and we do fellowship in child psychiatry, when I treat some parents, I've taken some of the more inattentive, sweet little girls, taken them off meds once the parents were medicated. It's kind of funny, right? You guys are going to go home and think about it. Wait till later in this talk how many of you guys diagnose your spouse, okay? All right, so potential areas of impairment. Watch what happens when I click. So, ADHD can impact any area of life. You guys get that? It impacts. It causes functional impairment. There's been longitudinal studies done for over 18 years where they've taken kids growing up into young adults. They followed them on meds and off meds. What do we know? If we look at this, the kids that weren't treated for ADHD that grew into adults, greater school dropout, less academic achievement, less high school graduation, less post-grad, less more multiple job changes, less overall income, 5 times as many driving infractions, twice as many car accidents with a worse outcome, earlier unwanted pregnancies, earlier sexually transmitted diseases, earlier onset of substance abuse. Did I miss an area? Obviously financial and other issues, and then what I said, risky and other issues that lead to problems in life, including injury and mortality. So here you see the same concept. What do we see? A much higher incidence of ADHD. Adults are fired, incarcerated, arrested, at-fault car accidents, I told you that, illness and accidents, substance abuse, sexually transmitted disease, teen pregnancy, failure to graduate high school, and the history of repeating grades. So I have 8 kids because of a remarriage, and 4 of them have ADHD. And they're adults now, but when they were teenagers, I knew about the long-acting meds. I looked at the driving studies. I promise you there's no reason to let your adolescent that has ADHD take a car on the weekend unless they've taken meds that day. And I'm not joking. The driving studies showed statistically significant improvement in driving when people were taking long-acting stimulants. Even when they took a 10 to 12-hour long-acting stimulant at 8 in the morning, when they did midnight drives, the drives were better on the day that they took the medicine. Okay, so if you just think of all the adolescents that fight their parents and young adults that don't want to take it when they're not at work, there's rationale that goes beyond just work or academics. Major life activities impaired. What you see clinical, I think, means other psych stuff. But what you really see is that what do we see? All areas of life. Home, academic, and work, and social. We see an impairment in functioning caused by ADHD. Money management problems? You guys could guess it, right? Think of how many ADHD people probably bet a lot, gamble a lot, make really poor decisions, impulse buying, impulse spending, right? So if you look at this data, you see how the difference between ADHD people, the amount they save, retirement spending, and even having to have utilities shut off. Okay, we're going to ask another question. You guys ready? Based on registry studies, people diagnosed with ADHD at which of the following ages have the highest risk for death? Under 6, 6 to 17, over 18, or there's no difference in mortality risk. This is the age they were first diagnosed. Okay. What do we see? We see significant higher risk of mortality and when people are first diagnosed as adults. What's going to be one of the take-home messages? I already brought it up. Think of how many people come in that have already been treated or diagnosed for an anxiety disorder or a mood disorder, a substance use disorder, or even autism spectrum or even Tourette's or other comorbidities that we look at. But you have to look beyond it when you really realize what's happened in their life that hasn't been positive. So what we see, risk of injury, we see the difference between untreated and treated children with ADHD and without ADHD. And what do we see? Obviously, the non-treated kids have a much higher risk of injury. The interesting thing is just seeing the young kids. I mean, you can picture why young kids, like with ADHD, get injured a lot. They're so impulsive, right? Another question? Ready? Guys awake? Good. Based on a large national cohort study, about what proportion of ER visits due to motor vehicle accidents among adults with ADHD could be prevented with consistent use of ADHD meds? 0 to 5%, 10 to 20, 25 to 35, or greater than 50%. Okay, what do we see? In women and men, we're looking at like 27 to 34% of motor vehicle accidents can be prevented. The last one's even more remarkable. Those are motorcycle accidents. We're looking at 50% can be prevented by taking your ADHD meds. You would get why ADHD people might ride motorcycles more than non-ADHD people. They like the rush, and they like the you know. Do you guys have friends with, adult friends with ADHD? They're your most fun friends, right? I mean, come on. We have a lot of energy, you know. Sometimes it's used negatively. That's the point of this talk. Diagnostic criteria. So we're looking at the DSM-5, but what we see is more than anything, it's a neurologic disorder that, what's the point of this talk? It affects every area of life. Morning, midday, afternoon, night. So what do we see? We see psychiatric comorbidities, which we will talk about, medical considerations. The core symptoms are in the middle of inattention, hyperactivity, and impulsivity, and distractibility is part of inattention. And then you see the 4 areas of life: home, social, work, school. So the cool part about the DSM-5, one, if you see at the top, you'll see next that there's a list of 9 core symptoms of inattention and distractibility and a list of 9 core symptoms of hyperactivity and impulsivity. It used to be that you couldn't diagnose an adolescent or adult unless they had 6. Well, the psychiatric community realized that we were not diagnosing enough adolescents and adults, so they lowered it for 5 for adolescents and adults. The age of symptoms, you have to see some evidence of ADHD before age 12. It can be compensated for, right? How many of you guys have diagnosed or treated like a freshman or sophomore girl in college and diagnosed her with ADHD, right? A lot of these girls are being diagnosed. Why? They were like sweet, not acting out kids, good IQ, good family structure, and the teachers and the parents helped compensate for it, right? And they probably played sports and did stuff regularly in high school, and then they get to college and all the compensation's taken away, and boom, you see it. But if you look back, teachers made remarks about, like, these kids, they just didn't meet the criteria, or they were doing well. That was a mistake. The impairment of symptoms cause functional impairment in more than one setting, okay? And they can cause functional impairment in school or work or social or personal. You can't diagnose ADHD if you're just doing poor at work. There's got to be evidence of impact in other area. And obviously we look at that the symptoms aren't a result of anything else, which is the key issue with comorbidity. But the key issue that separates ADHD out is this issue of symptoms are present before age 12. There are medical conditions like diabetes and celiac sprue and other issues that we know help people be inattentive, and anxiety and depression. People are often inattentive and distracted, but those are more episodic. Those don't present consistently before age 12. These are the 9 core symptoms of inattention: easily distracted, not having trouble following through, having trouble seeming to listen, difficulty sustaining attention, especially when you're not interested, poor attention to details, making careless mistakes, avoiding, disliking, or reluctant to engage in tasks that require sustained mental effort, like charting, right? I treat a lot of physicians and nurse practitioners and physician assistants, and the ones with ADHD, what's their largest complaint? The part of their work they hate the most, okay? Difficulty organizing, losing things necessary for tasks or activities, or forgetfulness. Then the hyperactive, impulsive, fidgets, taps, squirms, leave seats, on the go, driven by a motor, feeling restless, can't be quiet in leisure activities, talking excessively, interrupting, blurting out, difficulty waiting. Go see me at the airport in a couple hours when my meds wear off. I'm group 1. United gave it to me just to get me out of the way, okay? The other issue with ADHD is that, like, a lot of people are really smart who have ADHD. And when you look at adults who weren't diagnosed, look at this graph. You see that most ADHD people have higher than average IQ. The kids with severe learning disabilities or lower IQ, they're going to get caught earlier because of school issues and behavioral issues. And when people are unsuccessful, they start acting out more, right? Especially kids. And those kids get caught earlier than the higher IQ kid. All right, comorbidities. You see this number? Comorbidity of adults with ADHD approaches 40% of adults will meet the criteria of one mood disorder that are diagnosed with ADHD, either major depression, bipolar, or dysthymia. 40%, pretty real. Anxiety even approaches 50% if you look at the different anxiety disorders. GAD, panic disorder, OCD, social phobia, PTSD, agoraphobia. So you can see why a lot of these people get diagnosed with the comorbidity first. 50%. Screening, obviously it's important. So we have question number 5. Ready? Everyone paying attention? No, you're not. A 41-year-old man presents complaining of feeling stressed and overwhelmed. He's recently divorced and has a 12-year-old son who was diagnosed with ADHD. Family history. He has a prior history of major depression, which was treated with an SSRI. He asked if an antidepressant might help him now. So which of the following would be the most appropriate first step at this time? You can refer him to a specialist, prescribe a trial of an SSRI, prescribe a trial of a short-acting stimulant, or administer ASRS or ADHD-RS rating scales. The ASRS is a self-reporting scale. And the ADHD-RS, you can report yourself and other people can fill it out. Got me feeling like $1 million bill right now. Time to kill, I'll be up on the hill with a funny cigarette and a smile. Okay. So this is an algorithm that was put together by one of the speakers here. So what do we start with? We start with obviously medical and psych history. We look for a diagnosis of any medical issues, and then obviously psychiatric conditions and what meds people are on, because meds can lead to symptoms of ADHD, right? Side effects and adverse events of other meds. Family history, parents, siblings, or other family members showing symptoms of inattention. Parents or siblings being diagnosed with ADHD, and do you have a child? Family history is a little tight in psychiatry. You guys get that, right? The stigma, people don't really talk that much. So, and you don't really know what your aunt who had a insulin shock therapy 30 years ago, you don't know what she really had because the psychiatry's come such a long way. But most people don't talk about psychiatry. Most people don't even know that their nephew's been diagnosed with ADHD, right? So you got to really push, and you got to push people to talk and get past the stigma. Developmental history, tell me your school history. Look at school records. Every adult I see, I still try and get some report cards if they have them or if their parents have, because you see words on these report cards that like are kind of key indicators of just being impulsive or inattentive or distractible. Do you recall comments from teachers regarding your behavior, and did you have to repeat a grade, or when did you finally start doing better in school? We look at specific for education and vocation, occupational history, social functioning, but we ask about ADHD symptoms in all these settings. All right, I like this. So you might not always be able to do this. Psychiatrists, obviously, we can do it. I try and get data from other family members, for sure. One, there's a lot of adult malingerers. You guys get that? Like when an adult comes in and they don't want you to talk to their spouse, their boss, or give you any history, and all they want is immediate release mixed amphetamine salt, you know you're being played, right? When you start getting 4 referrals from the same fraternity, because you put one kid on an immediate release med and all of a sudden 3 other boys are like looking for assessments for ADHD, you know they're working you for. The immediate release meds have more likability on the street. We know that, okay? So I interview other family members to get past the malingering and just to get more data of where it's interfering. But I use rating scales actually with family members if they can't be there. And then the past management strategies used by a family or patient, that's what helped compensate. Did you play sports up to this point? Were you exercising? How did your mom help you? Did you have an assistant at your work that did something and then they left, and all of a sudden you don't have your secretary or your personal assistant anymore? Then we screen for ADHD, and if we can, we make the diagnosis. If not, when do we refer to a specialist? Obviously, if you're uncertain of the diagnosis, if you're not sure of the treatment options, patient has significant comorbidity, it makes a lot of general practitioners uncomfortable. If the symptoms don't respond to medications that you've used already treating ADHD, and if there's a joint need of the patient and physician for help in areas where the psychiatrist has more expertise. Okay, so it's nice to know the numbers, meaning rating scales. So which is the best scale to detect an inadequate response to an ADHD medication? You can use rating scales to see. You could use a rating scale before, and then when someone's on meds and they're tolerating it, you can repeat the rating scale. But my gut feeling is it's great, but if you're treating adults, they're going to tell you how much better the meds are and where things have improved. You might not need it, but one of the best rating scales for me is the ADHD-RS scale. You see the Connors and Vanderbilt. It's really easy to fill out. It's available. It's free. And remember those 18 points I showed you? The ADHD-RS makes an adult prompt scale. So what did they do? They take every one of those core 18 symptoms, and then they give 5 examples of how it might look in an adult. Okay? Being restless. What would be 5 ways you might see if an adult's really restless? Then we like the adult the self-reporting screener. If you want, there's the 6-question subset one. It's the screener. It takes 6 other questions from the 18 questions that you'll see, and then it kind of gives you a quick screen. And what does it focus on? More inattention than impulsivity, because I told you the impulsivity and the hyperactivity kind of shifts as adults. It doesn't show itself as much. So this is the adult ADHD self-report scale. You guys have this in the back of your book, right? So they wanted me, and they wanted us to have you guys give it to each other, but we're going to do something different. Each one of you guys take it right now. Yeah. Just fill out your adult screener.
For those of our viewers that are at home, if you go under the resource section on your computer screen when you logged in or where you see your information at. So under the resource section, you will be able to click on there and you'll be able to find a copy of the ASRS screener that you can take this at home as well. For those of you that are here with us, take a couple minutes and please do the screener.
Are you guys leaving because you don't want to do the screener, huh? A lot of people are in denial, you know. It's a normal defense mechanism. If you can't focus on doing it, that's an indication. You just, you know.
All right.
You guys mostly done?
Oh, come on. You only got a couple seconds here.
You finish
This
up.
is supposed to be ADD.
Who's done? Keep reading. I mean, keep doing it while we talk, okay? Because we're gonna let you guys talk right now. But one of the reasons why we had you do this is to realize how short it takes to fill out a rating scale. Some of you guys complete. So you could actually give this to your patients in the waiting room at the beginning or before, and they can take it, and other people can fill out rating scales while they're waiting, and it's not like a half-hour horrible procedure. Okay, Deborah.
We wanted to find out. How did you like it?
Oh, I thought it was very easy, and maybe I have a mild case.
All right, how many of you guys are thinking about yourself right now, now that you filled it out, all right? The 3 sitting next to each other, the friends, right? Last week in Phoenix, 3 people raised their hand that that their spouses had it. One person in the back texted her spouse while she was answering Deborah's question. She's like, I'm texting him right now. It's ridiculous. He covered all 18 areas.
So, yeah.
So what do you guys think of this? I mean, give us your thoughts on it, positive or negative.
Was it something that you felt that when you think about your patients taking it in your office and waiting to take it or taking it, and you're sitting there waiting for them to take it now, do you have a different perspective on what they're doing? Did you find you had to think about it a little bit to say, do I really do that?
No, I mean, right. It'll lead your patients then to get into the areas of functional impairment, right? And then the nice part about it is you don't even have to score it if it's fast because you start looking towards the gray, right? So when you see heavy gray versus no gray, you're gonna like maybe even raise your ideas. So it's even easy to use as a clinician because you don't even have to. If you want, you'd score it based on how you score it, or you really look how far to the right we go. Do you guys think you might start thinking about like this concept? You know. Any other thoughts or ideas? Why do you guys think you haven't? Did you think it before today? The three ADHD musketeers over there? You all 3 raised your hands. Did you think you might have had it before today? Yeah, okay. All right. All right, so how do we treat it? Key part of this talk. We're going to ask another question. You guys ready? Which of the following agents is a stimulant that is FDA approved for adults with ADHD and has the longest duration of effect in this category? The name brands will be on the next slide. You guys want to know the name brands? I see people staring. Atomoxetine is Strattera. Lisdexamphetamine is Vyvanse. Oros methylphenidate is Concerta. And then the 3 beads of mixed amphetamine ER is Mideas.
There will be an answer, let it be. For though they
Somebody have a
may
question?
be parted, there is still a chance that they will see.
We'll get to questions.
There will be an answer.
Okay. All right, so we're going to go over the different. So what the pharmaceutical industry has done is it's taken. You know, there's either methylphenidate or amphetamine. Are there D and L methylphenidate and D methylphenidate? Is there straight D amphetamine and D and L amphetamine and 3 parts D to 1 part L? But they're all methylphenidate or amphetamine. And those are immediate release meds that last, and depending which product, 2 to 5 hours after onset, right? So what the pharmaceutical industry did over the years was develop ways for these molecules to be delivered longer, right? So one of the typical beaded release deliveries, if you know mixed amphetamine salts, XR, or even like metadate or Focalin XR, dexmethylphenidate, you have 2 types of beads. Every bead is immediate release. One bead, you see the immediate release bead pops and dissolves right when you take it based on pH. The second bead, as you go through the intestine and your pH, increases in number, there's an outer coating that pops or breaks down based on pH. So then you get a delivery. So you're really looking at basically like a BID delivery, right? The Oros technology is very interesting. It's a capsule that can't be opened or broke, and it's excreted in the feces. The outer part of the capsule has 15 or 18% of the methylphenidate in it on the outer part of the capsule. So right when you take it, that is dissolved, and the person takes it, gets 18%. You see the 3 compartments? The bottom compartment has a chemical in it that's called the push compartment. It has a hole. The second compartment, compartment number 2, has a higher amount of methylphenidate in it than the drug compartment number 1. So drug compartment 1 has methylphenidate, drug compartment 2 has a higher amount of methylphenidate. And then what happens as water enters the push compartment, the chemical expands. As the chemical expands, it pushes the methylphenidate out the top of the capsule. So it's a very cool delivery system, but it is impacted by GI transit time. What is a prodrug? Lisdexamphetamine is a prodrug. What this means is that there's a lysine molecule attached to the D-amphetamine, and the lisdexamphetamine is 100% D-amphetamine. So when the lysine molecule is attached, the D-amphetamine is not active, okay? Because of rate-limiting enzymes, the lysines then cleaved from the D-amphetamine. When it's cleaved, the D-amphetamine becomes active. So it's done on a rate-limiting step. So you now have a medicine that in the adult studies showed up to 14 hours effectiveness. What's different about this med? The release of the active ingredient doesn't rely on GI transit time or pH because it's a prodrug. It has been shown to have less likability, okay? So if I were speaking for the pharmaceutical industry, I could not tell you that one product is less abusable or more abusable, okay? But what I can tell you about the studies with LDX, there is 2 sites in this country that get meth addicts and coke addicts and bring them in and let them try these things, okay? So they give them immediate release meds, they let them snort them, smoke them, use them IV, and then the extended release meds like LDX did this study, they let them use it IV, snort it, smoke it, and use it orally in low doses and then in high doses. What came out of the LDX study, because of the lysine being attached to the D-amphetamine, it's only released in the gut. What came out of it was low likability. What does that mean? The buzzheads didn't like the buzz, okay? You follow me? Can I tell you that means it's less abusable? Absolutely not. The FDA won't let you go there. We look at what's likable. What came out of the LDX study What was likable? High dose immediate release dextroamphetamine. No hepatic drug-to-drug interactions. 14-hour duration of effect in adult workplace settings. This is the adult study of LDX. Okay, so these are the meds. I'm going to add 2 more at the end of this that currently have FDA-approved indication for adults. The first one is Strattera, an atomoxetine. It's a non-stimulant. The rest are stimulants. So you have dexmethylphenidate XR, which is a beaded delivery system. You have the Oros methylphenidate, which is the Oros delivery system. You have mixed amphetamine salts, normal XR, which is a 2-beaded delivery. You have LDX, which is the prodrug delivery. And then you have the 3-beaded delivery, which is now similar to mixed amphetamine salts 2-bead, but there is now a 3rd bead that pops later. So in LDX, in the triple bead, in the adult studies, there were 16 hours effect shown. So that 3rd bead pops after the 2nd bead of the mixed amphetamine salts extended release. Guys ready for a question? We're going to end on time, I promise you. A 30-year-old woman presents with a chief complaint of restlessness and difficulty concentrating. She says she has often had these problems, recently started a new job, worried about being able to focus about her long workday. Why do a lot of adults come see me to get diagnosed? Because they change jobs and they're worried about losing the new job because it requires, they went from sales to sitting at a desk. You know what I mean? They went from something active where they could use their sarcasm and wit to just sitting in front of a computer. Evidence-based workup, including thorough history and diagnostic tools, supports a diagnosis of ADHD. If you diagnose ADHD, which of the following might be appropriate to address her concerns? Start with atomoxetine, prescribe a long-acting stimulant, Q-day, basically QAM, prescribe short-acting stimulants, BID, prescribe a long-acting stimulant, and add a short-acting stimulant as needed. Okay, I made the same mistake last week. Can you go back to that med slide like you did last week? Remember I told you I was going to tell you about 2 other meds? Okay, so there is a extended release methylphenidate delivery that's an oral suspension. Okay, and it's based on this new microparticle delivery technology. That is indicated for adults. And then there is a extended release amphetamine medication that's an ODT, oral disintegrating tablet, that also, by a different company, has this new microparticle delivery technology. So you have 2 more products that have adult indication. One's an ODT, disintegrates. It doesn't dissolve. It's not sublingual. It just disintegrates. It's swallowed in the saliva. And then the other's a liquid oral suspension, methylphenidate. Okay, so this is the LDX adult study. And what you saw from the first test point where they used, the PERM means they took math tests. Okay, so at 2, 4, 8, 10, and 12, and 14, the adults took LDX and then took these math tests. What do we know from all the child studies? Stimulants don't make you smarter. Okay, they make you more efficient. So what do we see? We see more math problems attempted and more math problems correct. And what do you see in the adult study? You see at every time point, including hour 14, that they had the same near same improvement in amount attempted and amount correct. This is a thing showing the 3rd bead. So what do we see? We see the PK curve on the top is the triple bead delivery. The PK curve on the bottom, which I'll show you, is taking the mixed amphetamine salt 2-bead, and then at hour 8, adding immediate release mixed amphetamine salt. So you added 2-beaded amphetamine, 25 milligrams, immediate release 12.5, versus the 3-beaded 37.5. Can you look at a PK curve and then think clinical? You're not allowed to. You have to separate out PK plasma stuff from what we know clinically, but what we see here is a peak to trough. We see a drop, and what that means to me is, you guys, do you treat ADHD where you give an immediate release med? The idea of that patient remembering to take it at the right time and coming off it and doing the next thing, so there's no way it's as smooth and consistent day to day to do it, but it is a logical option for some people when they need more than like the 10 to 14 hour coverage. Okay, summary. Takeaways. Highly genetic neurologic condition, 0.75 heritability. Some people think closer to 0.8. Causes impairment where? Everywhere. Untreated ADHD has significant morbidity and increased mortality. Measuring symptoms improves treatment because we diagnose it better and we follow a response. Short-acting stimulants do not have specific indications or safety data for adult ADHD. So the American Academy of Child Analysis and Psychiatry came out with a statement last year saying you should start with extended release. There's no reason to start any child, adolescent, and they didn't talk about adults, on immediate release when you have extended release meds that cover all areas of the day, right? And a lot of people think that you start with immediate release med because what if they have a side effect? And then once you know that they're on an immediate release methylphenidate, you switch them over to extended release. There's absolutely no indication or justification for doing that. One, if you guys have ever taken these meds, the immediate release meds have the same risk of side effects, but they feel different. You come off it, you come off it, and these newer delivery systems that we talked about might have an easier come off, might be smoother throughout the day and more consistent. So you're better off starting with the med that you think they're going to like better in a good way, not in the drug abuse liking way. Okay. What do? We look for efficacy and minimal adverse events, right? Long-acting once-daily medications should be used to optimize symptom control. So what people really should do is start out with an extended release medicine. Figure out which one your patients can take, the onset, the offset, their adverse events, how they feel during the day, and then stay with that. If they need to augment, you either go to a longer-acting one, or at that point, you might consider augmenting as needed with an immediate release. Ready for questions? So I get paid more based on your level of improvement. That's not true. The IT guys get paid more based on how well you do, right? All right, after participating in this program, how often will you utilize rating scales to screen patients for ADHD prior to making a diagnosis or offering treatment for ADHD? Never, rarely, sometimes, very often, always.
Seems like you get to slam in your face. That's when you need someone.
That's pretty good change, huh? Obviously, she told you in the other one, 82. The green is what you guys said first. I'm looking for heavy red on the bottom, you know. After participating in this program, please rate your confidence in your ability to select pharmacological therapy for your adult patients with ADHD. Not at all confident, slightly confident, moderately confident, pretty much confident, very confident.
You know how I feel. It's a new dawn. It's a new day. It's a new life for me.
Pretty good. Obviously, we just went over, you know, you guys will learn to use some of these meds and then feel more confident, obviously, but you get the idea. Based on registry studies, people diagnosed with ADHD at which of the following ages have the highest risk for death? Under 6, 6 to 17, over 18, no different in mortality risk by age at diagnosis. Well done. You guys got it. I taught one thing, right? I could go home feeling good about myself. Based on a large national cohort study, about what proportion of ER visits due to motor vehicle accidents among adults with ADHD could be prevented with use of ADHD meds in these patients? 0 to 5, 10 to 20, 25 to 35%, or over 50?
Everybody was dancing in the moonlight. Everybody here is out of sight, but they don't bark and they don't bite.
Okay, the answer really is 25 to 35%. The greater than 50% would be if you included the motorcycles. So there's a much higher incidence of ADHD in this room than any of you guys admitted. Or it's the end of the day, and I'm never doing the last talk again, okay? All right. A 41-year-old man presents complaining of feeling stressed and overwhelmed. He's recently divorced, has a 12-year-old son who was diagnosed with ADHD. He has a prior history of major depression, which was treated with an SSRI. He asks if an antidepressant might help him now. Which would you do first? Refer to a specialist, prescribe an SSRI, a short-acting stimulant, or administer a rating scale?
I've been sleeping here instead. I've been sleeping in my bed. Sleeping in my bed. So show me family.
Yay. All right, so well done. Give you guys a clap for yourself. Okay, which of the following agents is a stimulant that is FDA approved for adults with ADHD and has the longest duration of effect shown in studies in this category? Strattera, atomoxetine, lisdexamfetamine, Vyvanse, Oros methylphenidate Concerta, 3 beads of mixed amphetamine. Mixed amphetamine means 3 part D, 1 part L, amphetamine. ER, 3 beads is the Mideus. My day is really good.
What it might have been if you took a bus to Chinatown. I'd be standing on Canal and Bowery. She'd be standing.
Well done. Atomoxetine is a non-stimulant, but the 3 beads is the one that had the 16-hour data. Okay. The 30-year-old woman presents with a chief complaint of restlessness and difficulty concentrating. She says she has had these problems, but recently started a new job and is worried about being able to focus throughout her long work days and throughout the whole workday. An evidence-based workup, including thorough history and diagnostic tools, supports a diagnosis of ADHD, which might be the appropriate first step to address her concerns. Prescribe atomoxetine. Prescribe a long-acting QD, QAM, extended-release med. Prescribe a short-acting stimulant, BID. Prescribe a long-acting stimulant in addition with an immediate-release stimulant.
Gonna go to the place that's the best. When I lay me down to die, going up to the spirit in the sky. Going up to the spirit in the sky. That's where I'm gonna go when I die. When I die.
Yay. You guys are good.
There you go.
I don't,
All right.
so I want to make one point. Is that okay, Deborah?
Yes,
So
you
like,
may.
as a child psychiatrist standing up here, you guys have to understand the impact of ADHD is the sequelae of ADHD. You guys get that? That's why we bring up every area of life. When you treat kids with ADHD or adults, what do you hear? All the negative reinforcement they've gotten. And what do they end up feeling? Lower self-esteem, lower confidence, lower everything. And then do you wonder why they go into adulthood like having troubles at the areas of life that we talked about and don't experience much success? So one of the reasons we treat adult ADHD and we look for it before the mood disorders and the anxiety disorders, because when you treat people with ADHD and they're more successful, you see a lessening of the comorbidities because they're less stressed and less demoralized, right? More successful. All right?
There you go. Good point. Are there any questions for Dr. Feld? Here you go.
Hi, I just wanted to know, how do you interpret the results on the screening? At how many would you consider putting somebody on medication?
Wait, I'm not sure what you mean by interpreting the results of what?
On the screening, the self-reporting.
Oh, on the
scale,
screening, right?
yeah.
So the rating scale is just data. The rating scale gives you a view, or it raises your level of suspicion as a general practitioner, but you have to get clinical other issues. You have to get everything we talked about, evidence before age 12, where it's interfering and how it's, so then I put that together with a clinical picture. And then what was the second part of the question?
I was just wondering, is there a certain number where you might consider, but I guess.
I mean, it depends which rating scale they tell you, but I use that number knowing it's mild, moderate, and severe tied in with the functional impairment. So I really look for the gray area on the ASRS, right? But then I'm not worried if someone doesn't rate as high as possible if they've lost this many jobs in this, because rating scales are just still up to who's filling it out. Do you know what I mean? So I don't follow strict numbers, but I look for improvement on it. Okay. In the back.
Part of the problem with ADHD, child or adult, is first admitting that there is an issue. How do you overcome that for like the screening to be factual? Because being honest about certain things are, is hard for people.
No, I told you most people lie when they walk into a psychiatrist's office. I promise you. Okay, yeah, I'm a therapist. I do therapy. It's unbelievable what it takes for someone to even become honest. But here's the issue. When you really ask the questions about functional impairment, and you look at their educational history, and you look at their job changes, and you look at their rate of divorce, and you look at what happened, how many tickets they got, and you look at how much they gambled, and you look at when they started doing drugs, and how much pot they smoke at night, and what they do to settle themselves down for bed, you have a window into introducing, I might have something that makes sense to help you, not experience this anymore.
How do you get there?
Well, I think you get there by using a screener if there's any suspicion, based on what they tell you. And you looked at these case studies, talked about not sleeping, being stressed, worried about their new job. Son has ADHD. Then I think you use your screener, and then I think you introduce the concept that I'm going to look at this. I want to look to see if this is part of the picture. And this isn't a bad thing. You know how I get there mostly? I promise you, functional ADHD adults are your favorite people. Do you guys get it? They're a little more sarcastic and witty and high energy and just move around and enjoy life in a way. The ones that aren't functional are the opposite end of the scale. So my point to them is I want your life to be better, more functional, and you to feel better about yourself. So we got to look at potentially all reasons. And ADHD is not a bad thing. I debunk the myth. You know what I mean? But that's the part of mental health. Same idea telling someone they meet the criteria for major depression, bipolar, anxiety. You got to debunk the myth. ADHD's. I'm a neurologist. You know what I mean? In a way, right? I tell a lot of people that don't believe in psychiatry, think of me as a neurologist. Then you might like me more. Because psychiatry has this stigma. I'm not going to I don't dress like this, you guys. This is coming off in 10 minutes, okay? But so you have to just really show them that you're really looking at their life and try and help them feel better, and then debunk the stigma. It's not a bad thing. These meds are really safe,
So that brings us to a question that the viewer at home has. If an adult does not want to start with meds, what other options do you have?
Oh, there's lots of options. I mean, one you start with, there are types of therapy that help people learn how to address the executive function issues and look at areas of their life and reasons why, whether it's a CBT or a traditional therapy. But you look at issues with what area of their life they're struggling, and then you help them figure out what they have to do to implement to make changes. What do I look at first? Exercise. I think everybody in the world should exercise, but people with ADHD clearly do better when they exercise. I look at sleep, the amount of sleep they're getting. I look at how much light exposure they're getting. And I look at nutritional issues also. Because every one of you guys in this room has a food intolerance. I played soccer in college, and I didn't want to be on meds because they had short-acting meds back then. Same idea, right? And I had a sports psychologist teach me because I could not study after soccer practice. So what happened? I found out that I don't do well with protein. I'm like a carbo insensitive person, and I'm a protein sensitive person. So when I eat carbs, I'm good. When I eat a protein, I just want to be distracted and lay down. So there's non-med things you can do, right? So we implement all these strategies: organization, structure, figuring out where you can get compensation, where you're struggling, who you can get to help you, and then when the wheels aren't on the train track can't move forward. So if we implement other stuff, we take meds to put the wheels on the track. We still do everything we're talking about to that same person.
Can you suggest any other resources that they can go to for patients with mental disorders?
I'm not sure. What I would do, I'm sure diagnostically, I don't think there's a set ADHD. I think you have to read the people that know what they're doing. Do you know what I mean? Like Russell Barkley and people from, you have to know where the data's coming from. Do you follow me? There's a lot of things on the internet that look pro-ADHD or really pro-mental health, and they're driven by the Church of Scientology, and by the time you get halfway through the article. So I think you have to trust that you have to look at data coming from the top people, like at Harvard, the top people that are the well-known thinkers in a field, and that's the book you really want. That's the data you want to read. There's 50 books out about self-help and what to do for ADHD. You just got to know who it's coming from and if it's readable.
All right, so one final suggestion or question here. Do you treat adults? Because this individual is in the Illinois area and her PCP always wants her on SSRIs and anti-anxiety meds. She was totally in that gray area for that evaluation, and she would like to know, do you treat adults? Or he, she or he.
Well, no, I already said that. They weren't paying attention. That's why they have ADHD, right? Like, I'm an adult psychiatrist first, right? You guys get that? Child psychiatrists do a fellowship, but we're trained adult psychiatrists. Can I treat 100% of my patients under age 17? Absolutely not. And I told you, I treat kids, and then I give the parents rating scales because I believe in genetics. So the parent walks in, I'm like, who's got it, right? We're in the family, jokingly, and then all of a sudden it's always this other side of the family, right? Or it's clear who did it, and then I start treating the parents because I honestly think you look at the kids' lives get better when their parents are gainfully employed, getting along better in their relationship, drinking less, doing the things that we want them to do, but also being less emotionally impulsive. Adults are very emotionally impulsive with ADHD.
All right. Join me in thanking him.
All right, good.
Very much, Dr. Bell. We appreciate that greatly.
What?
And so for our viewers at home who are asking about the ASR, look under the resource section. Under the resource section on your website when you went to log in, you will find the ASRS guide there. You can download it. If you have any difficulties, please let NACE know, and we will make sure you get a copy of it. Otherwise, everyone here at White Plains, you did fantastic. Please pass along the message that NACE would like to come back for the 8th year, and we want to have 2 full rooms, not just 1. So we thank you very much for joining us here today. Have a safe trip home. There is still some coffee there. There are no coffee tops, so don't ask us for coffee tops. Otherwise, we do thank you very much. Have a good day.